Hello, welcome to Mod Midwives, a Metro Midwifery podcast. I'm Gina Gerboth.
And I'm Nedra Hale, and we are home birth midwives serving the Denver metro area.
So for today's podcast, we're going to build on our previous podcast where we talked about the shared decision-making tool. Because as clients, you have a number of decisions that you have to make during the course of your care. So today we thought we would talk about ultrasound in pregnancy, as that's one of those decisions that almost everybody is at least thinking about at some point in their pregnancy.
Right. So as you probably know, ultrasound is a very common procedure that is done in pregnancy. And it's even something that people do for fun now and or have been for a while, I suppose. I shouldn't sound like an old lady. But, you know, you have all the keepsake ultrasounds and the boutique ultrasounds and 3D and 4D and...
How many D's can there really be? Seems like a lot of D's.
Yes. So obviously what we are involved with and, associate with our care is the screening ultrasounds and clinical ultrasounds is what we would call them.
Mm-hmm. Yeah. So the reason that we're saying screening instead of diagnostic ultrasounds is that the ultrasound that you would get in a pregnancy is usually just kind of a peek in. It's kind of a first look to see if there's anything that looks like it's out of the ordinary or
right.
Outside of normal. So it's important to remember that the ultrasound itself is very unlikely to be able to give you a definitive answer about very many things.
Yes. Yes. I mean, I think probably every practitioner out there has had experience with something that went undiagnosed on a screening ultrasound. I don't think it's terribly common. I have no data on that, but
it's actually pretty uncommon to have a false negative. So ultrasounds are pretty accurate when it comes to ruling out problems.
Yeah, I mean, I think it's in the cases I'm thinking of, it is less a problem of the ultrasound itself and more a problem of the interpretation of the ultrasound. So it was a human
error. And that's really an important point to make, because it's not just a technical, calibrated, quantitative kind of a test. This is definitely one of those things that there's somebody interpreting what they see.
But you're totally right. I mean, so many more times I've had ultrasound results come back with a possibility of something.
Right.
And then with further testing, that thing ended up to not be a problem.
Right. So it's kind of a... So one way that we describe this is to say that it's casting a wide net. So it's throwing it out there. It's going to pick up a lot of stuff, but some of that stuff isn't going to be stuff that you want. So it's going to be those false positives occasionally.
That's good.
So, the studies are pretty, there's a lot of variability in what they say that's called the sensitivity, the ability to detect the true positives. There's a lot of variability in what you see about how sensitive ultrasound is, but somewhere anywhere between 85 and 95% of the time they'll catch true positives. But that leaves a pretty big margin of error for those false positives too.
Right, definitely.
So, whereas the sensitivity, the ability to catch the true negative or to identify the true negatives is, in the 99% range. So it's much more likely if they say everything looks normal, that's more likely to be true.
That it is the case.
Yeah.
Yes.
Human error notwithstanding.
Right, exactly.
So
that's the wild card.
Yeah.
So do we want to start with what, like the typical ultrasounds that a person would run into? Let's just say in a standard obstetric model of pregnancy, and then how that might vary. Okay.
Yeah.
So first trimester ultrasounds then. Most people, I guess, would have a first trimester ultrasound in an obstetric practice. Yep. Some of our clients do, but it is, 100% offered as a choice, unless there's some clinical indication for it. We don't know the dates or something like that. So, and that's the main thing. We were looking for dates and we're looking for viability on the
Right.
first trimester ultrasound.
Right. So sometimes people have had a previous miscarriage or a series of previous miscarriages, and they really want that first trimester ultrasound for reassurance, so that can happen.
Right.
So it could be a choice, again. And it's always a choice, but
Right.
But what you're saying is that it's not necessarily part of our routine care.
Right. I suppose I should say instead of choice that it is just one of the options presented.
Sure.
And we most of the time don't feel a large investment in that first trimester
Right.
ultrasound again, unless there is a question of
Right.
dates.
An indication for
Unless there's an indication. So that some of our clients choose to do it and many of them don't. So
Yeah, I actually don't even have stats on how many
Yes.
of our clients do 50-50, maybe not even. Maybe
yeah.
not even. But in an obstetric model, you're right. That would be that would be part of routine care, would be to get
Yes.
that first trimester
Yes.
ultrasound. So pretty much everybody, unless you decline, would get it. So I do want to say one thing about this, and that is when we have uncertain dates, which
Yes.
in our practice is very common.
It is true.
Because we have people that are often breastfeeding from the previous pregnancy still,
Yes.
and maybe have never had a period or have had one period in the past 3 months, and it's
Yes.
just really unreliable as a identifier of your due date sometimes. So they are more likely to
Yeah,
want to figure it
if
out.
we're needing some reassurance on dates, it is the best time to get an ultrasound because it's going to be the most accurate
Yeah.
for that dating piece.
Yeah. And sometimes it's really easy to think, oh, well, it doesn't matter. Babies come when they come. But
It does matter.
it does matter, because when we get to 42 weeks and it's not actually 42 weeks, or when we
Right.
think you're 36 weeks and you're actually 40 weeks,
I mean, the truth is we need a framework to work within
to provide.
to make sure that, everything is progressing normally for the pregnancy. So it affects everything,
Yes.
our measurements, and
Right.
of course, at the end of pregnancy, it's a really big deal if our dates
Yes.
are off.
That's when it's really the biggest deal, for
Yes.
sure. So that would be times when we would recommend one, when we would actually say, well, we would
Yes.
recommend that we get an early ultrasound to figure out
Right.
what your dates look like.
Absolutely.
Yeah. And another thing that a first trimester ultrasound can do is rule out twins.
Oh, that's nice. Yes.
Because otherwise, we might not discover that until 20 weeks.
Yeah,
or
I
later.
mean, so what happens with that in my, small experience with having twins show up in my practice is that we end up not getting an ultrasound till, let's say, 16 weeks or something, when they've arrived at their visit and they're measuring much larger than they should. And, so then we have the ability then to figure out the twin thing, but the dating piece is not as accurate.
Right.
Yes.
Right. I've actually had 2 sets of twins that we didn't do a first trimester ultrasound and weren't really sure, and it was picked up at the 20-week ultrasound. So
Yeah.
so it definitely can happen later. That
Yes.
it's and I've even heard of it being completely missed until delivery.
I have also
so.
heard of that.
Yeah, interesting. But so that would be a first trimester ultrasound. Then I think the next most common ultrasound in our practice would be that 20-week or anatomy scan, we often call it.
Right. I always call it the 20-week ultrasound, whether it occurs
At 20 weeks.
at 20 weeks or not.
Right. I usually say between 18 and 22 weeks.
Exactly.
So,
Yes.
the 20 weeks being the middle
Yes.
of that time.
So this one is one that I actually do recommend, and you do as well. It's mainly it's just that there's so much important stuff to see. The position of the placenta is really important. We have to keep in mind that we are having our baby outside of hospital, and we just want to know where everything's at as much as we can. And I as a provider, that is important information for me. That being said, sometimes people don't want to have one. So
Again,
yeah.
in that shared decision-making
Right.
framework, it is still a choice.
Right.
But
right.
I think here we would say it's our routine practice to offer an ultrasound at 20 weeks, whereas we would
Yes.
maybe not have a routine practice of a first trimester.
Right. And is this the right time to say
Oh, it doesn't matter.
that we also do have circumstances where it is
Right.
a
requirement to
requirement for our
continuing care.
practice, to in those circumstances would be if somebody's having a VBAC, for example, we do want to know where that placenta is because that's an extra risk factor.
And in case anybody doesn't know, VBAC is vaginal birth after cesarean.
Oh, right.
So we
Right.
need to take a look at the placenta location and make sure that it's not covering the
Yes,
previous scar.
there's a small increased risk of an accreta, and so we want to rule that out. There might be other reasons that come up during pregnancy, such as if the growth of the uterus is not appropriate for dates, that would be a reason why we'd have to have a discussion about ultrasound and definitely recommend that we take a look in there.
So those are, really strong indications for one, and that's where that weighing of the pros and cons and risks and benefits can come out differently for different situations, not just different people.
Right. It's kind of like we've mentioned before that we, you have your normal trajectory, and then you have other discussions you have when we're deviating from normal. Yeah.
Another time is when we're getting really close to 42 weeks, 41 and a half weeks or something like that. It's nice to have that ultrasound to provide some reassurance that the baby's continuing to grow well and that the fluid levels look good and that all of that stuff is looking normal. So that would be another time when we might kind of more strongly recommend an ultrasound. All of these times are pretty rare. It's very rare that we're like, you have to get an ultrasound.
Right. Yes. I
Or
just like
unusual, I
to
should say.
just like throw all the contingencies into the discussion. The other important thing. Oh, go ahead.
Oh, I was going to say that goes back to a conversation we had a number of episodes ago where, we kind of have a roadmap of where we're going at the beginning of care, but sometimes we have to stop and go sightseeing along the way, and we have to be flexible and realize that we're kind of responding to what's happening in your pregnancy at that time.
Right.
We can't promise that there won't be something that we're wanting to take a closer look at later.
Right. Because every single pregnancy is different.
Yes.
So with that 20-week ultrasound, the other important thing that we're looking at is the anatomy of the baby. And it's much easier to see all of the things that need to be seen at this stage of pregnancy versus earlier or later. Because later on, it seems like at your first thought that it might be easier to see that stuff as the baby gets bigger and bigger, but it's actually not true. It's because they start getting, running out of room, and then you've got limbs covering things because they're starting to fold into that so-called fetal position. And
I wonder where that came from.
why it's called that. And so around 20 weeks is a great time to look at the heart, the lungs, the kidneys, make sure everything's normal with the brain. And, I think that's really important information.
And I think one of the myths almost, or the misconceptions, it's probably not really a myth that I hear, is that, we don't want to find out the baby's sex, so we don't need to do the ultrasound.
Right.
When we actually don't
We
care
don't care
about the
that.
baby's sex. We don't care at all. You may care very much, but we are completely neutral. We actually just want to make sure that all that organ formation is happening, placenta looks good, and like you said, that we're staying in that low risk category for home birth.
Right.
So,
Exactly.
yeah. Speaking of myths, have you heard myths or questions or misconceptions or concerns that you want to address today?
About ultrasound?
Yeah, sorry.
So, of course, we have a handful of people every year that don't want to have ultrasounds. And I'm not always clear on all of the current information about what the reasons are that people don't want to. But what I've heard is a risk of autism by ultrasound. I've heard people say that it causes growth restriction.
Oh, I haven't heard that.
That it causes molecular changes because of heating from the ultrasound.
I have heard that.
I can't think of anything else offhand.
Yeah. So, there has been quite a lot of research on ultrasound done over the years because it's been around a while.
It's been around for a while.
I don't know when routine ultrasound really kind of came on the scene, but it was well before we started having babies.
Yes.
In the 90s.
Yes.
So yeah, there's a number of studies that have been done. And so I would, as I looked over the balance of evidence, really there's very little that demonstrates harm or demonstrates significant risk. However, I want to caveat that and say that the research also says we don't really know what the threshold for safe use is.
Right. So it's similar to a whole bunch of things that we find out information as we go in medicine and so many other things as well. So the fact that we have all of these years without adverse outcomes that are documented, at least, that's very reassuring. But that doesn't mean that it's all there either, right?
Right. And some of the studies say it appears that it's safe even with several ultrasounds per pregnancy. But in some practices in the obstetric model, it's not uncommon to get an ultrasound at every single visit.
Right.
And so that could be one of those things that we also would kind of question and say, well, where's the evidence that shows that that's safe?
Right.
Because we don't necessarily have it. But we do have a good amount of evidence that shows that limited ultrasound use is safe in pregnancy.
Right.
And something could happen. For example, the concern about heating the tissues or the amniotic fluid or whatever gets heated.
Yes.
Because there is heat generated when molecules move around.
Right.
But that doesn't necessarily mean that it's clinically significant. So even if it gets a little warmer, it's temporary and it's not necessarily having an impact.
Am I wrong in thinking, and it's been a really long time since I've read anything about the heating part, but I'm remembering that when they're talking about the heating, that it's different. It's not obstetric ultrasound that they're talking about.
That could very well be because sometimes ultrasound is used therapeutically.
Right. There's all sorts of different ultrasound devices and
there's
applications.
different levels that are used in different situations, and so yeah, I think you're right. So definitely people will want to weigh the concerns that they have. And then try to find, kind of dig in and see what kind of evidence you're finding and ask your midwife to help you with that. But also weighing the fact that, like you said, we are about to have a birth in an out-of-hospital environment.
Yeah.
And making sure that all of the ducks are in the row for that to be as low risk as possible.
It's nice to have as much information as is available.
And we've both been surprised by situations that either were missed on the ultrasound or there wasn't an ultrasound.
Right.
And of course we just deal with it in that moment. But when you kind of take that look back after the birth and say, oh,
I wish I had known about that.
That would have been nice to know. So,
For sure.
So also in line with the frequency and how much we don't know about that is this trend of the boutique or keepsake ultrasounds.
Going back to the boutique ultrasounds. And I mean, it's just a matter of that there is so much variability in how these places are monitored or not. They might not be monitored at all. And so, at least in my mind, the quote unquote fun ultrasounds, they definitely fall in the category of why expose the baby to extra ultrasound that is not being regulated.
And we might need a diagnostic ultrasound or a more high level ultrasound later for reason. We might have a reason for it later. So don't use it up on on a keepsake. And they are not actually recommended by the FDA or I think even ACOG or whoever. They're the keepsake ones. They're what their stance is that they should be reserved for clinical purposes.
I mean, those crazy, grainy ultrasound pictures that I got in the 90s were good enough for me. So they should be good enough for everybody
I know.
else,
I
too.
couldn't even tell. I did want to know my first baby's sex, and we couldn't even tell. Like, it was just so not unusual to not be able to tell.
Yes.
And
it's
now there's
true.
like a,
Actually, they're so good now.
I know. And if they can't tell, they'll have you come back and do it later. It's so funny.
Oh.
Well, like they never would have done that
Yes.
back in the
Yes.
day. So let's see. I thought we could talk about the process of getting an ultrasound in our practice. That's going to be different
that's
from
good.
location to location.
Right.
So we have a couple places that we offer ultrasounds. I mean, we don't offer them, that we refer you to for ultrasounds. And so it kind of depends on your insurance coverage and your medical need and your out-of-network deductibles and all of that, or not out-of-network, your insurance coverage is what I was looking for.
Right.
You know, all of those, your
Because
financial.
the ultrasound people are probably going to be in network.
Yeah, they're almost always. But like, for example, if you have Kaiser, the other places won't cover it. So you
I
kind of need to
see.
go to Kaiser.
Yeah, so
is
sometimes
kind of what I'm trying to say.
Okay, you're saying the insurance might
Yeah.
dictate where you go.
Yes,
Okay.
yes, sorry. So if you have Kaiser, we obviously don't really refer directly to Kaiser, with some exception. I have referred people to maternal fetal medicine at Kaiser, and it's been very easy to do
good.
that. So for a high-level ultrasound, to double-check something. But usually you just call, you make your own appointment with Kaiser. Kaiser has they have a
Right.
system. So
Otherwise, we would fax in an order to one of our places that we use routinely, and it's very easy.
And so one place we use is more of just a general imaging center, which is good. I've heard of other obstetric practices using them, so they do a good job. It's not to say that it's not a good
Right, but it's just
place.
a standard screening ultrasound.
So if somebody had special concerns, it would not be the
Yes,
best place to go.
right.
Or we also utilize
Utilize.
the university's perinatology center.
Yes.
And so that's where you can get kind of a much higher level ultrasound.
Yes.
A lot more input about it, and you also get a consultation with the perinatologist.
Right. So some people choose that. For example, I chose to go to a perinatologist for my 20-week ultrasound for my last baby just because of my age, and just, wanted some extra time, extra looks, and make sure that everything was good. And then the consultation piece and all of that. So,
The consultation is great because this is not what we do. This is not our area of expertise.
Right.
We don't interpret ultrasound reports. If you went to an imaging center, they do have a radiologist interpret it. So there is still a physician looking at the report.
Right.
But it's not necessarily somebody who looks at obstetric ultrasounds hundreds of times a day.
right.
Day
They're
in and
looking
day
at
out.
veins and they're
Yes.
all sorts of
All
things.
kinds of different
Yes.
things. So that's, sort of a different level of care. And all of that being said, the perinatology center is in network with almost all insurances except Kaiser. And so most insurance will cover it. And so you can get a pretty great high-level ultrasound for, within your insurance network stuff.
Right.
I know that I'm not using the right financial terms. Sorry. They're all leaving my head. All the terms in my head are leaving. And so just a caution about making sure that you really do have some kind of system set up that a physician is reading this, because it's not necessarily
Right.
easy to
Right.
detect all of the things
Yes.
that could be detected on an ultrasound.
Yes.
So
It's very important.
yeah. So definitely taking the time to get that referral and go to a really high quality place.
Yes, for sure.
And then one other thing I want to talk about, sorry, I know that I keep throwing things out here. Some people do not want to do ultrasound in pregnancy, and they just want to avoid it altogether. But one other thing that we want to just mention is that Doppler is also ultrasound.
Yes.
So when you come into the office, we usually listen to the baby's heartbeat with a handheld Doppler. And just for people that are wanting to avoid all ultrasound, you should just, for full disclosure,
Just so you know.
that is ultrasound technology.
Yes. So some people then would choose to listen with a fetoscope
Correct.
instead, which does not use ultrasound. But you should know that we can't hear the baby
For a
as
while.
early. Yes, not for a good long
Kind
time.
of a long while, actually.
Yes.
Yeah. And I've had
Yeah.
clients who have used the Doppler one time early to get that first one,
Yes.
just so they can have
So
that
they're
reassurance.
in between
Yeah.
options for
Yeah.
sure.
It's not all or nothing.
Yes.
Although we talked a little bit about some of our practice restrictions.
Yes.
So one of our practice restrictions was that if you've had a previous C-section, we really feel strongly that you need to have an ultrasound.
Yes.
Another practice restriction we both have is that we don't believe that we can monitor the baby effectively without using Doppler in labor.
Yes. So, and this is something we discuss in the interviews, so that people know what we need going in, because it's a partnership. So, so if what we need is not suitable for what they want or need, then they are free to
pick a provider
that
doesn't
matches
have
up better,
yeah.
right? Yeah.
Doesn't have that requirement.
Yes.
So, but I think it just is important to know that many midwives may have that.
Yeah.
And the evidence actually does show that outcomes are better with
Right.
intermittent auscultation with a Doppler.
Right.
Intermittent auscultation means that we listen to the baby periodically throughout labor rather than continuously monitoring the baby. But it's the Doppler allows kind of
that beat to beat variability is much easier to hear.
Yeah. So it's sorry. It's a good way. It's the best way for us to get a great sense of what the baby's doing.
Yes,
How the baby's
absolutely.
tolerating labor, and the baby's heartbeat is really the only way that they have to communicate with
Our
us.
lifeline, so to
Yeah,
speak.
so we need to hear the baby during labor. And
Yes.
many people who want to avoid ultrasound and Doppler use in pregnancy are still fine with that because
Yeah, I mean, I'm struggling to think if I've ever had anybody
I was the assistant in a
leave
birth
my
once.
practice because of that issue. I don't think so.
No, me either.
Yeah.
But I mean, then again, we disclose it up.
Yeah, we're very,
Yeah. So, but I have been to births where they didn't want it in labor either. And I mean, of course, that's a personal choice, but you just want to make sure you find that provider
that the
that's comfortable
provider
with
is
that.
comfortable. Yes.
Yeah. So again, this could be you could take all this information into consideration when you're making this decision with your midwife about what to do for ultrasounds and pregnancy and
Right.
and again, weighing out the pros and cons and risks and benefits is just a really important piece of getting to that
Right.
decision for you. And some people will probably be listening to this and will be like,
Why?
yeah, yes, I want an ultrasound.
Yes.
And some people will be like, no.
Yeah.
not for me.
Yeah. I mean, it's an individual decision.
Yeah.
So
Yeah. So go back to the previous blog post for the shared decision-making tool
Right.
if you want to print it out and have that available as you kind of wade through this decision for yourselves.
yes, absolutely.
So that's all we've got today. Make sure that you check us out on Instagram and Facebook and Twitter, and all of our handles on those apps are at Metro Midwifery.
Yes.
And then you can find us at www.metromidwifery.com. And stay tuned.
And modmidwives.
modmidwives.com too. Yes, why do I always forget that?
Yes.
modmidwives.com. You can find all of our podcasts if you want to go back and catch up.
Are you tweeting on your personal Twitter these days, Gina?
My last tweet was about how much I hate Spirit Airlines, so I should probably go tweet something
If you want to
else.
see us be grouchy, you can
You
go
can go to
to our
Twitter.
personal Twitters.
I would like to point out that I got a refund of $178 because
You did?
I did.
Oh, that's great.
It was horrible. It
So
was
squeaky wheel.
squeaky wheel gets the grease.
Yes.
Yes. The views and opinions expressed about Spirit Airlines belong to Gina Gerban alone. Insert disclaimer that needs to be made here. So.
Yes.
Okay. All right. Well, everybody have a great week.
Thank
and
you for joining us.
Yeah, we'll see you next week. And I kind of forget what our topic is, but it will be something exciting.
Oh, it's home birth.
Oh my gosh, that's right.
How could you forget?
Next week we'll be talking about why home birth.
Yes.
So join us then. Bye.
Bye.